Afternoon class. Today we're going to continue Unit 8, Chapter 22, Part B, the Respiratory System. Part 2, Respiratory Physiology. Section 22.4, Mechanics of Breathing. So pulmonary ventilation consists of two phases, inspiration and expiration. In inspiration, gases flow into the lungs, and in expiration, gases exit the lungs. So pulmonary ventilation is the physical movement of air into and out of the respiratory tract. The primary function of pulmonary ventilation is to maintain adequate alveolar ventilation, which is movement of air into and out of the alveoli. Alveolar ventilation prevents the buildup of carbon dioxide in the alveoli and ensures a continuous supply of oxygen that keeps pace with absorption by the bloodstream. Pressure relationships in the thoracic cavity. To understand this mechanical process of the movement of air, we need to look at some basic physical principles that govern the movement of air. One of the most basic is that our bodies and everything around us are compressed by the weight of Earth's atmosphere. Although we are seldom reminded of the fact, this atmospheric pressure has several important physiological effects. So atmospheric pressure is the pressure exerted by the air surrounding the body, and it's 760 millimeters of mercury at sea level, and that equals to 1 atmosphere. So respiratory pressures are described relative to the atmospheric pressure. So negative respiratory pressure is less than the atmospheric pressure. Positive respiratory pressure is greater than atmospheric pressure, and zero respiratory pressure is equal to atmospheric pressure. Intrapulmonary pressure is a pressure in the alveoli. It's also referred to as intra-alveolar pressure. It fluctuates with breathing, and it always eventually equalizes with the atmospheric pressure. On the other hand, the intrapleural pressure is the pressure in the pleural cavity. It fluctuates with breathing. It's always a negative pressure, and it's usually always 4 millimeters of mercury less than the pulmonary pressure. The fluid level must be kept at a minimum. Excess fluid is pumped out by the lymphatic system, and if the fluid accumulates, then the positive intrapleural pressure develops, and then the lung collapses. Two inward forces promote lung collapse. The first one is the lung's natural tendency to recoil. Because of elasticity, the lungs always try to assume the smallest size. And second is the surface tension of alveolar fluid. The surface tension pulls on the alveoli to try to reduce alveolar size. One outward force tends to enlarge the lungs. That's the elasticity of the chest wall pulls the thorax outward. The negative intrapleural pressure is affected by these opposing forces, but is maintained by a strong adhesive force between the parietal and visceral pleura. Pressure is the transpulmonary pressure, which is the pressure that keeps the lung spaces open, and it keeps the lungs from collapsing. Greater transpulmonary pressure, the greater the lungs will be. The lungs will collapse if the PIP is equal to the P pole, or PIP is equal to the atmospheric pressure, and a negative IP pressure must be maintained to keep the lungs inflated. Okay, so figure 22.14, intrapulmonary and intrapleural pressure relationships. Okay, so let's look at the picture first. So we have the lungs, and then we have the parietal pleura, the visceral pleura, and the pleural cavity. So we talked about the atmospheric pressure. That's the pressure that surrounds the body. Then we talked about the intrapulmonary pressure, the direction of airflow is determined by the relationship between the atmospheric pressure and intrapulmonary pressure, which is measured inside the respiratory tract at the alveoli. And then we have the interpleural pressure. The interpleural pressure is the pressure measured in the space between the parietal and visceral pleura. And then we have the transpulmonary pressure, which basically prevents the lung from collapsing. So figure 2215 shows pneumothorax. Okay, so rupturing either the parietal or the visceral pleura can cause pneumothorax. So on the left, a punctured parietal pleura from, let's say, a knife wound, or a ruptured visceral pleura, often spontaneous, is going to cause pneumothorax, where it's going to cause air in the pleural cavity, and it's going to cause the intrapleural pressure to become equal to the intrapulmonary pressure, and as a result, the lungs collapse. A collapsed lung is called atelectasis. Clinical homeostatic imbalance 22.7. Atelectasis is lung collapse that can be due to plugged bronchioles, which cause the collapse of the alveoli, or due to pneumothorax, where air goes into the pleural cavity. This can occur from either a wound in the parietal pleura or rupture of the visceral pleura, treated by removing air with chest tubes, and when the pleurae heal, the lung reinflates. Pulmonary ventilation consists of inspiration and expiration. It's a mechanical process that depends on volume changes in the thoracic cavity. The volume changes lead to pressure changes, and pressure changes lead to flow of gases to equalize the pressure. An inverse relationship exists between the pressure and volume of a gas in a closed container, where gas pressure is inversely proportional to volume. And this is first recognized by Robert Boyle in the 1600s, and it's called Boyle's law, which is the relationship between pressure and the volume of a gas. So gases always fill the container they are in. If the amount of gas is the same and the container size is reduced, the pressure will increase. So pressure, or P, varies inversely with volume, V. So mathematically, it's P1V1 equals to P2V2. Let's look at inspiration. So the active process involving inspiratory muscles, in other words, the diaphragm and external intercostals. So the action of the diaphragm, when the dome-shaped diaphragm contracts, it moves inferiorly and flattens out, and it results in an increase in the thoracic volume. For the action of the intercostal muscles, when the external intercostals contract, the rib cage is lifted up and out, much like when the handle on a bucket is raised outward as it moves upward, and that results in an increase in the thoracic volume. Figure 2216, changes in thoracic volume and sequence of events during inspiration and expiration. Okay, so in inspiration, the top one, the sequence of events, the inspiratory muscles contract, so the diaphragm descends and the rib cage rises. The thoracic cavity volume will increase. The lungs are stretched. Intrapulmonary volume increases. Intrapulmonary pressure drops, and the air flows into the lungs down its pressure gradient until intrapulmonary pressure is 0 or equal to atmospheric pressure. And so the changes are the ribs are elevated and the sternum flares as the external intercostals contract, and the diaphragm moves inferiorly during contraction. And you could see what happens if you look at the lateral dimensions or a superior view on the right. So as the thoracic cavity volume increases, the lungs are stretched as they are pulled out with the thoracic cage, and this causes the intrapulmonary pressure to drop by 1 millimeter of mercury, and so the pulmonary pressure is less than the atmospheric pressure. Because of the difference between the atmospheric and intrapulmonary pressure, the air flows into the lungs down its pressure gradient until the two pressures are equal. During the same period, the PIP lowers to about 6 millimeters of mercury, which is less than the atmospheric pressure. Forced or deep inspirations can occur during vigorous exercise or in people with COPD. The accessory muscles are also activated. Scalenes, sternocleidomastoid, and pectoralis minor. Erector spinae muscles of the back also help to straighten the thoracic curvature. And these act to further increase the thoracic cage size, creating a larger pressure gradient so more air can be drawn in. Quiet expiration normally is a passive process. The inspiratory muscles relax, the thoracic cavity volume decreases, and the lungs recoil. The volume decrease causes the intrapulmonary pressure to increase by 1 millimeter of mercury. And if the intrapulmonary pressure is greater than the atmospheric pressure, the air flows out of the lungs down its pressure gradient until the two pressures are equal. Forced expiration is an active process that uses oblique and transverse abdominal muscles as well as internal intercostal muscles. Figure 2216, we're looking at expiration. So inspiratory muscles now they relax. So the diaphragm rises, the rib cage descends due to recoil of costal cartilages, the thoracic cavity volume decreases, and the elastic lungs will recoil passively, and the intrapulmonary volume decreases. Intrapulmonary pressure rises, and the air or gases will flow out of the lungs down their pressure gradient until the intrapulmonary pressure is 0. And we can see the changes that occur in the thoracic cavity. So ribs and sternum are depressed as the external intercostals relax, and the diaphragm moves superiorly as it relaxes. And we can see the changes that happen in the lateral dimensions from a superior view as well. And we can see the external intercostals relax. 2217, changes in intrapulmonary and intrapleural pressures during inspiration and expiration. Okay, so let's follow the intrapulmonary pressure. So that's the pressure inside the lung. It decreases as the lung volume increases during inspiration. The pressure increases during expiration. If we look at the intrapleural pressure, that's in the pleural cavity. So the pleural cavity pressure becomes more negative as the chest wall expands during inspiration, and then it returns to initial value as the chest wall recoils. And in terms of volume of breath, during each breath, the pressure gradients move 0.5 liters of air into and out of the lungs. Non-respiratory air movements. So many processes can move air into or out of the lungs beside breathing, and they may modify normal respiratory rhythm. Most rests result from reflex action, although some are voluntary. Examples can be coughing, just a simple act of coughing, sneezing, crying, laughing, hiccups, and yawns. Factors influence the ease of air passage and the amount of energy required for ventilation, and these are airway resistance, alveolar surface tension, and lung compliance. Let's start with airway resistance. So friction is the major non-elastic source of resistance to gas flow, and it occurs in the airways. The relationship between flow, pressure, and resistance is a change in pressure over resistance is equal to the flow. So delta P is the pressure gradient between the atmosphere and the alveoli, which is 2 millimeters of mercury or less during a normal quiet breathing. The 2 millimeter of mercury difference is sufficient to move 500 mils of air. The gas flow changes inversely with resistance. So if resistance increases, then the flow will decrease and vice versa. Resistance in the respiratory tree is usually insignificant for two reasons. The first reason is that the diameters of the airways in first part of the conducting zone are huge, and second, the progressive branching of airways as they get smaller leads to an increase in the total cross-sectional area. Any resistance usually occurs in the medium-sized bronchi. Resistance disappears at terminal bronchioles, where diffusion is what drives gas movement. Figure 22.18, resistance in respiratory passageways. There's the conducting zone and the respiratory zone. That's shown on the x-axis, so that's airway generation, so stage of branching, and resistance to flow is on the y-axis. So you can see that the highest resistance to flow is found in the medium-sized bronchi, and it decreases as we reach the terminal bronchioles. As airway resistance rises, breathing movements become more strenuous. Severe constriction or obstruction of bronchioles can prevent life-sustaining ventilation, can occur during acute asthma attacks and stop ventilation. Epinephrine will dilate bronchioles and reduce air resistance. Physical factors influencing pulmonary ventilation, such as alveolar surface tension. So surface tension is the attraction of liquid molecules to one another at a gas-liquid interface. And it tends to draw liquid molecules closer together and reduce contact with the similar gas molecules. Resists any force that tends to increase surface area of liquid. Water which has very high surface tension coats the alveolar walls in a thin film. And this tends to cause the alveoli to shrink to the smallest size, in other words, to collapse. Surfactant is the body's detergent-like lipid and protein complex that helps reduce surface tension of alveolar fluid, and it prevents alveolar collapse. And remember, this is produced by the type 2 alveolar cells. Clinical homeostatic imbalance 22.9. Insufficient quantity of surfactant in premature infants causes infant respiratory distress syndrome, the increased surface tension results in collapse of alveoli after each breath. The alveoli must be completely reinflated during each inspiration, and this uses a tremendous amount of energy. This is very common in preemies. Fetal lungs do produce adequate amounts of surfactant until the last 2 months of development. In this figure, we see the normal alveoli, and here we can see on the right the collapsed alveoli. That is common in preemies, premature babies. Treatment: spraying natural or synthetic surfactant into newborns' air passages. The positive pressure devices also help to keep alveoli open between breaths. Severe cases may require mechanical ventilation. Survivors of mechanical ventilation may develop bronchopulmonary dysplasia, which is a chronic childhood lung disease. Lung compliance is another physical factor that influences pulmonary ventilation. Lung compliance is a measure of change in lung volume that occurs with given change in transpulmonary pressure. It's a measure of how much stretch the lung has. Normally it's high because of the distensibility of lung tissue and because surfactant, which decreases the alveolar surface tension. Higher lung compliance means it is easier to expand the lungs. Lung compliance can be written mathematically as CL, which equals to compliance. The delta VL equals the change in lung volume, and the delta pulmonary and PIP equals to the change in transpulmonary pressure. Compliance can be diminished by non-elastic scar tissue replacing lung tissue, as in fibrosis, reduced production of surfactant, and a decreased flexibility of the thoracic cage. Clinical homeostatic imbalance 2210. Any decrease in the natural resilience of lungs diminishes lung compliance, such as chronic inflammation or infections seen in tuberculosis can cause non-elastic scar tissue to replace normal lung tissue, and a decreased production of surfactant can also impair lung compliance. The lower the lung compliance, the more energy is needed just to breathe. Total compliance of the respiratory system is also influenced by compliance or distensibility of the thoracic wall, which can be decreased by deformities of the thorax, ossification of costal cartilage, which is common in old age, and paralysis of intercostal muscles. Section 22.5, assessing ventilation. So several respiratory volumes can be used to assess respiratory status. Respiratory volumes can be combined to calculate respiratory capacities, which can give information on a person's respiratory status. Respiratory volumes and capacities are usually abnormal in people with pulmonary disorders. Spirometer is this original, cumbersome clinical tool used to measure patients' respiratory volumes. However, electronic measuring devices are used today. So, tidal volume is the amount of air moved into and out of the lung with each breath, and it averages approximately 500 mils. The inspiratory reserve volume is the amount of air that can be inspired forcibly beyond the tidal volume, and this varies between 2100 and 3200 milliliters. The expiratory reserve volume is the amount of air that can be forcibly expelled from the lungs. This is between 1000 and 1200 milliliters. And the residual volume is the amount of air that always remains in the lungs, and this is just what is needed it's enough to keep the alveoli open. Respiratory capacities, combinations of two or more respiratory volumes. So inspiratory capacity is the sum of the tidal volume plus the IRV. The functional residual capacity is the sum of the RV plus the ERV. The vital capacity is the sum of the TV plus IRV and ERV, and the total lung capacity is the sum of all lung volumes. Figure 2219, respiratory volumes and capacities. So here's a spirographic recording from a male. Okay, so here on the y-axis we have measurements in milliliters. Okay, so the tidal volume we said is about 500 milliliters. The inspiratory reserve volume is around 3100 milliliters. And if you take the tidal volume plus the IRV, you get the inspiratory capacity, which is about 3600 milliliters. Here, if we go back, the expiratory reserve volume is about 1200 milliliters, and the residual volume is 1200 milliliters, and the functional residual capacity is 2400 milliliters, so you're adding the ERV and the RV. The vital capacity is you're adding the IRV, the TV, and the ERV. And it's around 4,800 milliliters. And the total lung capacity also takes into account the residual volume. So it's around 6,000 milliliters. So here it summarizes for an adult male what the average value is, and for an adult female, the respiratory volumes and respiratory capacities. This is in figure 2219b. And it also tells you what it is. So tidal volume, we said, is the amount of air inhaled or exhaled with each breath under resting conditions. The IRV, or inspiratory reserve volume, is the amount of air that can be forcefully inhaled after a normal tidal volume inspiration. Expiratory reserve volume, or ERV, is the amount of air that can be forcefully exhaled after a normal tidal volume expiration. And the residual volume is the amount of air remaining in the lungs after forced expiration. And then we have respiratory capacities. A total lung capacity is adding the tidal volume, the inspiratory reserve volume, the ERV, and the residual volume. Vital capacity is adding everything except for the residual volume. The inspiratory capacity is adding the tidal volume and the IRV, and the functional residual capacity is adding the ERV with the residual volume. Dead space. So dead space represents the volume of ventilated air that does not participate in gas exchange. There are two types of dead space: anatomical dead space and alveolar dead space. So anatomical dead space does not contribute to gas exchange. It consists of air that remains in the passageways. So it's about 150 mils out of the 500 mils of the tidal volume. The alveolar dead space is the space occupied by non-functional alveoli, and it could be due to collapse or obstruction. And the total dead space is when you add up the anatomical and alveolar dead space. Pulmonary function tests. So a spirometry can distinguish between obstructive pulmonary disease and restrictive disease. Obstructive pulmonary disease is when there's an increased airway resistance due to, for example, bronchitis. And here you would have the TLC, the FRC, and the RV that may increase because of hyperinflation of the lungs. The restrictive disease is due to reduced TLC due to disease, for example, tuberculosis, or exposure to environmental agents and resulting in fibrosis. The VC, the TLC, the FRC, and the RV decline because the lung expansion is compromised. Pulmonary function tests can measure the rate of gas movement. So forced vital capacity, the FVC, is the amount of gas forcibly expelled after taking a deep breath. The forced expiratory volume, or FEV, is the amount of gas expelled during a specific time interval of the FVC. And FEV1 is the amount of air expelled in the first second. Healthy individuals can expel 80% of the FVC in the first second, and patients with obstructive disease exhale less than 80% in the first second, whereas those with restricted disease exhale 80% or more even with reduced FVC, or forced vital capacity. Alveolar ventilation. So minute ventilation is the total amount of gas that flows into or out of the respiratory tract in 1 minute. It's a normal at rest is approximately 6 liters per minute. Normal with exercise is up to 200 liters per minute. Only rough estimate, it's only a very rough estimate of respiratory efficiency. Alveolar ventilation rate, flow of gases into and out of the alveoli during a particular time, and it's a better indicator of effective ventilation. The alveolar ventilation rate takes into account the amount of dead space, the tidal volume, and the rate of breathing. It can be calculated by the following equation. The AVR, measured in mils per minute, is equal to the frequency, which is breaths per minute, multiplied by the tidal volume, the dead space. So that's mils per breath. Because the dead space in an individual is normally constant, the AVR is affected by the tidal volume and the frequency. Significant increases in the AVR are brought about by increasing the TV, the tidal volume, rather than the frequency. Rapid shallow breathing can actually decrease the AVR. Table 22.3. This is just effects of breathing rate and depth on the alveolar ventilation of 3 hypothetical patients. One is seen normal rate and depth. So the dead space is 150, tidal volume is 500, respiratory rate is 20 breaths per minute. Minute ventilation is about 10,000 mils per minute, and alveolar ventilation rate is 7,000 mils per minute, and it's about 70% effective ventilation. One who is breathing, the second patient, they're breathing a slow, deep breathing. Dead space is not affected. Tidal volume is 1,000 mils. Respiratory rate is 10 breaths per minute. Minute ventilation is 10,000 milliliters per minute. The alveolar ventilation is 8,500 mils per minute, and it's about 85% effective. In the third scenario, the patient is breathing rapidly and shallow breathing. Again, the dead space is not affected. The tidal volume goes down to 250 mils. Respiratory rate is 40 breaths per minute. Remember, they're breathing rapidly. The minute ventilation is not affected. The alveolar ventilation rate is 4,000 mils per minute, and it's only 40% effective ventilation. Section 22.6, gas exchange. So gas exchange occurs between the lungs and blood, as well as blood and tissues. There's external respiration, which is the diffusion of gases between the blood and the lungs, and internal respiration, we said, is the diffusion of gases between the blood and the tissues. And both processes are subject to the basic properties of gases and the composition of alveolar gas. Let's examine the basic properties of gases. So in the 1800s, Dalton came up with his law of partial pressures, which states that the total pressure exerted by the mixture of non-reactive gases is equal to the sum of pressures exerted by each gas. So partial pressure is the pressure exerted by each gas in a mixture, and is directly proportional to its percentage in the mixture. Remember, the total atmospheric pressure equals 760 millimeters of mercury, and nitrogen makes up about 78.6% of air. Therefore, the partial pressure of nitrogen, Pn2, can be calculated. You multiply 0.786 by the partial pressure atmospheric pressure, and it's 597 millimeters of mercury due to nitrogen gas. Oxygen makes up the 20.9% of air, so the partial pressure of oxygen equals to 0.209 multiplied by 760 is 159 millimeters of mercury. Air also contains 0.04% carbon dioxide and 0.5% water vapor and insignificant amounts of other gases. At high altitudes, partial pressures decline, but at lower altitudes, like underwater, the partial pressures increase significantly. Table 22.4 is a comparison of gas partial pressures and approximate percentages in the atmosphere and in the alveoli. If you notice here, nitrogen gas, the partial pressure in the atmosphere at sea level, of course, is 597, whereas in the alveoli, it's 569. Oxygen 159 in the atmospheric sea level, and in the alveoli is 104. Carbon dioxide is 0.3 at sea level, whereas in the alveoli is 40. Water is 3.7, and in alveoli is 47. Total is 760 for both. Another basic property of gases is can be summarized in Henry's law. For gas mixtures in contact with liquids, each gas will dissolve in the liquid in proportion to its partial pressure. At equilibrium, the partial pressures in the two phases will be equal. The amount of each gas dissolved depends on the solubility. So CO2 is 20 times more soluble in water than oxygen, and little nitrogen will dissolve. Temperature also, as the temperature of the liquid rises, solubility is going to decrease. An example of Henry's law is seen in hyperbaric chambers. Mechanical homeostatic imbalance 2212. So breathing oxygen gas at 2 atmospheres is not a problem for short periods of time. However, oxygen toxicity develops rapidly when the partial pressure of oxygen is greater than 2.5 between 2.5 and 3 atmospheres. Excessively high oxygen concentrations generate huge amounts of harmful free radicals, and these can result in central nervous system disturbances, coma, and even death. Composition of alveolar gas. If you remember from the table I showed you, table 22.4, which was a comparison of the gas partial pressures and the approximate percentages in the atmosphere and the alveoli, we saw that for nitrogen gas and for oxygen gas, they were almost very similar actually, but not for CO2 and water. In fact, the alveoli contain more CO2 and water vapor than atmospheric air because of gas exchange in lungs. Oxygen diffuses out of the lung and CO2 diffuses into the lungs. Humidification by air by conducting passages, and also because of mixing of alveolar gas with each breath. Newly inspired air mixes with air that was left in passageways between breaths, which is actually very interesting because this does not happen in birds. In birds, they have a one-way flow of gases, and there is no mixing of air. It's actually a better system than seen in mammals, but that's just an aside. External respiration. External respiration, pulmonary gas exchange, involves the exchange of oxygen and CO2 across the respiratory membranes. The exchange is influenced by the partial pressure gradients and gas solubilities, the thickness and surface area of the respiratory membrane, and the ventilation perfusion coupling, which is a matching of alveolar ventilation with pulmonary blood perfusion. Pressure gradients and gas solubilities. The steep partial pressure gradient for oxygen exists between blood and lungs. In venous blood, the partial pressure of oxygen is 40 millimeters of mercury, whereas alveolar partial pressure is about 104 millimeters of mercury. This difference drives the oxygen flow into the blood, and the equilibrium is reached across the respiratory membrane in about 0.25 seconds, but it takes red blood cell 0.75 seconds to travel from start to end of the pulmonary capillary. And this ensures an adequate oxygenation even if blood flow increases 3 times. On the other hand, the partial pressure gradient for carbon dioxide is less steep. For venous blood, the partial pressure of carbon dioxide is 45 millimeters of mercury, whereas alveolar partial pressure of carbon dioxide is 40 millimeters of mercury. So the gradient is not as steep, and however, CO2 still diffuses in equal amounts with oxygen. And the reason for that is that CO2 is 20 times more soluble in plasma and alveolar fluid than oxygen. Here we have figure 2220, partial pressure gradients promoting gas movements in the body. So if you notice for the partial inspired air, the partial pressure of oxygen versus CO2, so obviously there's much higher O2 levels, right, going in than CO2 because of the atmosphere. And in B, we have the at the level of the alveoli of the lungs, 104 versus 40. And in C, we have blood leaving lungs and entering tissue capillaries. So here it's, 140 millimeters. So this is, directly going to systemic, right? Systemic circulation. And D is at the level of the tissues. The partial pressure of oxygen is less than 40. CO2 is greater than 45 millimeters. This is where the two get exchanged. And E is the venous return, right? The blood leaving the tissues and entering the lungs. The partial pressure of oxygen is 40, and that of CO2 is 45 millimeters of mercury. 2.21, oxygenation of blood in the pulmonary capillaries at rest. At the start of the capillary until the end of the capillary. So at the start, it's the partial pressure is 40 millimeters of mercury, and then it increases to 104 until the end of the capillary. Thickness and surface area of the respiratory membrane. So the respiratory membranes, we said before, are very thin. They're about 0.5 to 1 micrometers thick. The large total surface area of the alveoli is 40 times the surface area of the skin. Clinical homeostatic imbalance 2213. The effective thickness of the respiratory membrane increases dramatically if the lungs become waterlogged and if there's edema in the lungs, and this is seen in cases of pneumonia or when there's left heart failure. The 0.75 seconds that red blood cells spend in transit through the pulmonary capillaries may not be enough for adequate gas exchange, and the result is the body tissues suffer from oxygen deprivation. Clinical homeostatic imbalance 2214. Certain pulmonary diseases drastically reduce alveolar surface area. Examples are in emphysema, the walls of the adjacent alveoli break down and the alveolar chambers enlarge. Also, tumors, mucus, or inflammatory material can reduce the surface area by blocking gas flow into the alveoli. Okay, so figure 22 shows tissue changes in emphysema. And by the way, emphysema is a lung condition that causes shortness of breath. So we can see that in people with emphysema, the air sacs, the alveoli in the lungs are damaged. And over time, the inner walls of the air sacs weaken and rupture, creating these larger air spaces instead of many small ones in a normal lung. Ventilation perfusion coupling. So perfusion is blood flow reaching the alveoli. Ventilation is the amount of gas that reaches the alveoli. Ventilation and perfusion rates must be matched for optimal efficient gas exchange, and both are controlled by local autoregulatory mechanisms. The partial pressure of oxygen controls perfusion by changing the arteriolar diameter, so the diameter of the arterioles, whereas the partial pressure of carbon dioxide controls ventilation by changing bronchiolar diameter. Influence of local partial pressure of oxygen on perfusion. So changes in the partial pressure of oxygen in the alveoli cause changes in the diameters of arterioles. Where alveolar oxygen is high, the arterioles dilate, whereas where alveolar oxygen is low, arterioles constrict. This directs blood to go to the alveoli where oxygen is high, so blood can pick up more oxygen. The opposite mechanism is seen in systemic arterioles that dilate when oxygen is low and constrict when oxygen is high. In terms of the effects, the influence of local partial pressure of CO2 on perfusion, so changes in the partial pressure of CO2 in the alveoli cause changes in the diameters of the bronchioles, as we said. Where alveolar carbon dioxide is high, bronchioles dilate. Where alveolar carbon dioxide is low, bronchioles constrict, and this allows the elimination of carbon dioxide more rapidly. Balancing ventilation and perfusion. So changing diameters of the local arterioles and bronchioles synchronizes ventilation perfusion. Ventilation perfusion is never balanced for all alveoli because regional variations may be present due to effect of gravity on blood and airflow, and occasionally alveolar ducts are plugged with mucus that cause areas that would be unventilated. Figure 22-23 looks at ventilation perfusion coupling. So in A, ventilation less than perfusion. So there's a mismatch of ventilation and perfusion, which decreases ventilation and or increases perfusion of the alveoli, which causes local increases in the partial pressures of CO2 and a decrease in the partial pressure of O2. So the oxygen autoregulates the diameter of the arterioles. The pulmonary arterioles serving these alveoli will constrict, smaller diameter, and match of ventilation and perfusion, where there's a decrease in perfusion, which balances a decrease in ventilation. In scenario B, ventilation is greater than perfusion. So when there's a mismatch of ventilation and perfusion, it increases, let's say there's an increase in ventilation and or a decrease in perfusion of alveoli. This causes local decrease of partial pressure of CO2 and increase of partial pressure of oxygen. There's this autoregulatory mechanism where oxygen, the arterioles will dilate, will increase in diameter, as a result, there's going to be an increase in perfusion, which balances that increase in ventilation. Internal respiration. Internal respiration involves capillary gas exchange in body tissues. Partial pressures and diffusion gradients are reversed compared to external respiration. So at the level of the tissue, the partial pressure of oxygen is always lower than an arterial blood partial pressure of oxygen, where we have 40 versus 100 millimeters of mercury. So the oxygen moves from blood to tissues, and the tissue partial pressure of CO2 is higher, always higher than the arterial blood partial pressure of CO2, 45 versus 40. So CO2 moves from the tissues into the blood, and the venous blood returning to the heart has a partial pressure of oxygen of 40 and a partial pressure of CO2 of 45. Okay, so figure 22-20 again looks at the partial pressure gradients in different parts of the body, and these that promote gas movements. Okay, so in A, this is inspired air. Okay, so if you compare the partial pressure of oxygen versus CO2, 160 versus 0.3. B is at the level of the alveoli of the lungs, so 104 versus 40. Then C is blood leaving the lungs and entering the tissue capillaries. It's 100 versus 40. And then D is at the level of the tissues, and here it's 40 versus 45. And then blood leaving the tissues and entering the lungs. So this is the deoxygenated blood that comes back. So it's 40 versus 45 here, and then back into external respiration.